Good evening and welcome to tonight's program. Tonight we will be discussing improved assessment of severe and novel management strategies to alleviate the burden of CRS with NP, chronic rhinosinusitis with nasal polyposis. How to obtain CME and CE credit. So in order to get CME credit for participation in this live webcast, you must complete the pretest, view the program content, complete the post-test and evaluation form, and then a link will be provided to you with the post-test and the evaluation form, and then your certificate will be processed and emailed to you within 4 weeks after we receive your completed forms. So the faculty presenters for this evening are myself. I am Dr. Maeve O'Connor from Charlotte, North Carolina. I am clinical assistant professor at UNC Charlotte in the Department of Public Health, clinical adjunct professor at the University of Arizona at Tucson in the Department of Integrative Medicine, and I run Integrative Allergy and Immunology Care, as well as Allergy, Asthma, and Immunology Research Institute. And I'm also the Chief Medical Officer of the Consortium of Independent Immunology Clinics and Alexander Innovations International. My disclosures are listed below with my advisory boards, consultancies, speakers, and research. And I am pleased to also introduce to you my co-presenter, Dr. Kalinsky. Dr. Kalinsky?
Thank you, Dr. O'Connor. So my name is Nicholas Kalinsky. I'm from Knoxville, Tennessee. I currently work at the Allergy, Asthma, and Sinus Center of Private Practice. I'm board certified in allergy and immunology as well as internal medicine, and I'm the upcoming president of the Tennessee Society of Allergy, Asthma, and Immunology. Below, you can see my advisory boards and speaker panels I've served on.
Thank you, Nick. Our learning objectives tonight are listed here for you. We're going to discuss how to apply evidence-based guidance to assess the severity and quality of life impact of chronic rhinosinusitis with nasal polyps, which I will going forward refer to as CRS with NP. We're going to also describe how to incorporate current guidelines and expert recommendations into the positioning of biologic therapy, sinus surgery, and oral corticosteroids for the treatment of patients with CRS with NP. We're also going to summarize clinical trial data on the efficacy and safety of biologics and surgical options for patients with CRS with NP. So first, we're going to dive into discussing the disease burden of CRS with NP. So when we look at the prevalence of chronic rhinosinusitis, CRS with NP, and CRS without nasal polyposis in the United States, you can see that the prevalence is very high. So per the CDC, there are 28.9 million American adults who have chronic rhinosinusitis. And this number is very large. And if pediatric and adolescent patients were included, this number would be even larger. But per the CDC, we're just looking at the adults here. So that's a large number of patients, accounting for 11.6% of the total population having and suffering with CRS. So when we think about chronic rhinosinusitis, of course, we categorize it into CRS with or without nasal polyposis. Tonight's presentation, we're going to be concentrating on CRS with NP, which accounts for 20% of that 28.9 million Americans, and 80% of those patients have CRS without NP. When we think about disease severity, CRS with NP, we think about the symptoms as well as the impact on quality of life. So we've all seen patients like this in clinic who come in with the typical complaints that they will have, the symptoms of their sinonasal disease, which can include sinus headache, facial pain or pressure, nasal discharge, that can be rhinorrhea or postnasal drip, loss or reduction in sense of smell. And I will say this is the biggest complaint that patients have when they present to me with CRS with NP, that loss of smell. Nasal blockage or congestion is another one of the cardinal symptoms of CRS with NP. And two others that are important are other nasal symptoms or extra rhinologic symptoms, which actually can have quite an impact on these patients. When we think about those sinonasal symptoms, we typically think about what it does to their face and their pain and their smell. But there are other things that can cause an impact on quality of life by having these symptoms, including disrupted sleep or loss of sleep quality, social impact, not wanting to go to social activities, not wanting to leave their home, fatigue, loss of energy, just feeling tired. These patients can also have effects on their mood, including sadness, depression, anxiety. These patients can be very frustrated when they present to our office. They can have restlessness, tension, maybe tension headaches going along with that sinus headache. They can have loss of concentration and productivity, and that can be at work or at school. These patients are often embarrassed because they feel that their voices changed, or they can't smell things that other people can smell. And then there's the impact on their daily activities or work. So we can see that symptoms and quality of life are very impactful in these patients. Now, studies suggest that the quality of life impact of CRS with NP is comparable to chronic conditions such as type 2 diabetes, rheumatoid arthritis, and asthma. And these next three graphs are looking at comparing patients with CRS with NP to those other chronic conditions, rheumatoid arthritis, type 2 diabetes, and asthma. And as you can see here, taking the slide from left to right, we are seeing the 36-item short form questionnaire, the physical component summary, as well as the mental component summary. And you can see the normal population norm score for the physical component of this score is about 50. So when we look at the population of patients with CRS with NP, we can see that that is lower than the population norm for the physical component score. And rheumatoid arthritis is also low, type 2 diabetes, and asthma. But the purpose of this is to see that these are comparable. So CRS with NP patients often are not taken as seriously as the patients with these other chronic conditions, but you can see that the PCS-SF36 score is very comparable in these patients, as is the mental composite score. Population norm, again, being about 50. And other than rheumatoid arthritis being a little bit above this, we can see that that composite score for mental symptoms is comparable across CRS with NP, type 2 diabetes, and asthma. Now, looking at the right-hand side of the slide, the European Quality of Life Dimension Visual Analog Scale, we can see the population norm range of 70.4 to 83.3 on this EQ-VAS score. And again, we can see the comparability of CRS with NP, rheumatoid arthritis, type 2 diabetes. And when we look at asthma, in this case, asthma was categorized via GINA scoring, and knowing that higher GINA scoring, of course, being higher asthma severity. And even in moderate and severe asthmatics, we can see that that EQ-VAS score is comparable to patients with CRS with NP. So patients report unmet needs in CRS with NP, and we see these patients, they come into the office and they say they've seen multiple providers, they're still not better, and they want us to fix them, right? So in one-on-one interviews with 15 patients with CRS with NP that was conducted by Clays and colleagues to identify unmet needs in patients with CRS with NP, the burden of CRS with NP was addressed. And patients experienced a major impact of CRS with NP on their daily lives as a result of the wide variety of disease symptoms that we reviewed in the previous slide. The most frustrating aspect of disease was the impaired sleep quality, along with mental dysfunction and reduced smell capacity. As I mentioned, my patients always are complaining about not being able to smell. Again, from this article that was published in Frontiers of Allergy, there's also the underestimation of burden. So participants were incredibly frustrated about the underestimation of the burden of their disease and reported the importance of the psychosocial aspect, including mental health, sleep quality, and social function, often being forgotten. And as we pointed out in the earlier slide, these can have huge impact on a patient's quality of life. And they are often seeing providers who may underestimate the burden of how they're feeling. And this is particularly frustrating, as was pointed out in this one-on-one interview studies that were published. Another outcome from this was that findings highlighted coordination care as one of the key unmet needs. Doctors not talking to each other, healthcare providers not discussing things, or having differences of opinion as well. They just felt that their care was not coordinated. We see this often in our clinic. Another one was treatment limitations. Despite the many positive effects of sinus surgery and oral corticosteroids, there are many limitations, including disappointing outcomes and adverse events associated with the two major pillars of current treatment: the dependence on drugs and recurrent surgeries, restricting patients in their freedom. And we see this again and again with patients presenting with CRS with NP. So now we're going to look at assessment of disease severity and quality of life impact. So we have many available tools for the assessment of CRS with NP severity and disease impact. We have clinical reported measures, such as the nasal polyp score, which is on a 1 to 4 scale, the Lund-Kennedy endoscopic score, and then the Lund-Mackay CT score, mostly used in our ENT colleagues, but we have been using that much more in the allergy immunology world as we try to get prior authorizations for some of these medications that we're going to discuss. Another available tool are patient-reported measures, or PROs, of nasal symptoms. The SNOT-22 sinonasal outcome test is one that is often used in clinical practice as well as in research. Nasal congestion score, again, often used daily as well as in research, and others that are more often used in research. The University of Pennsylvania Smell Identification Test, or the UPSIT, Chronic Sinusitis Survey, CSS, Rhinosinusitis Disability Index, so that taking into account more of those comorbid symptoms such as fatigue, sleep disruption, and then the nasal polyposis quality of life, PRO. And then there's PROs looking at overall well-being, the 36-item short form survey that we've already looked at some results from, and then that European quality of life at 5D, or the EQ 5D. A single metric that accurately assesses disease severity in CRS should be easily quantifiable, reflect the impacts considered most important, and should directionally and proportionally change with disease exacerbations or treatments so that it can help us guide decision-making. And unfortunately, we don't have a single ideal metric that exists to help us assess disease severity in CRS. And the complexity of assessing severity in CRS is a result of several inherent disease characteristics that we've discussed already. But these are many of the available tools that are available to us for assessment of CRS with NP severity and impact on our patients due to their disease. So diving into a little bit more detail into the SNOT-22 for the evaluation of symptom burden and quality of life impact. The SNOT-22 is a 22-item disease-specific validated physician and patient-reported measure, PRO, patient-reported. Key diagnostic symptoms included as in the EPOS definition of CRS, and that's the European Position Paper on Rhinosinusitis, the EPOS, as well as other items of importance to patients with CRS. Values 50 or more identify severe disease, suitable tool for practice. I do use this in my practice. It's pretty easy to use, not like some of the research tools that are a little bit more burdensome. And the SNOT-22 is being very increasingly used, not only through ENT practices, but also allergy immunology, and also with our primary care colleagues as well. The symptoms that were reported by patients as being most important, so those other items of importance to patients with CRS, nasal blockage and congestion, sense of smell and taste, we see it again, thick nasal discharge, need to blow the nose, and postnasal drip or postnasal discharge. Now, the nasal polyp score is shown here. And again, as I mentioned, this is a score from 0 to 4, with 4 being more severe. Polyp size and location, as well as anatomic description. So score of 0 being no polyps, 1, small polyps in the middle meatus not reaching below the inferior border of the middle turbinate, and the more severe score of 4, large polyps causing complete obstruction of the inferior nasal cavity. We don't want patients to get to that severity before we offer them treatment options that may reduce some of their symptoms. Now, large nasal polyps may also be assessed by routine anterior rhinoscopy, and these polyps are evaluated on each side through nasal endoscopy usually, but some of them you can see on routine anterior rhinoscopy. Now, the nasal polyp score is the sum of the left and right nostril scores, and that's the NPS. And then severe CRS with NP as defined by an NPS score of 5 or greater. So those are the patients that we really need to be helping. So this is looking at comorbid type 2 inflammatory conditions that are associated with moderate and severe CRS with NP. And this image is looking at the distribution of physician-rated severity among United States patients with moderate to severe CRS with NP, and then it has the listed comorbid conditions. So in this study, 69% of CRS with NP patients had at least one type 2 comorbidity, and 36% had at least 2 type 2 comorbidities. So getting into a little bit more detail, among patients with moderate to severe CRS with NP and allergic rhinitis, 75% had moderate and 15% had severe allergic rhinitis. Among those patients with moderate to severe CRS with NP with atopic dermatitis, 47% were moderate, and 7% had severe AD. And of those with coexisting asthma, 60% had moderate and 16% had severe asthma. So the high comorbidity burden that's shown in this study in terms of the number and severity of type 2 inflammatory conditions, it really suggests the importance of identifying patients with type 2 inflammation so that we can best treat them. This high prevalence of coexisting diseases in these patients it really highlights the importance of assessing comorbidities as part of our routine care every time we see a patient, and the need for that integrated multidisciplinary treatment approach to not only address the patient concern that they want the multidisciplinary coordination of care, but also to address underlying type 2 inflammation, to improve the quality of life, and also just to improve overall outcomes in type 2 patients. So how do we look for type 2 inflammation? So this is showing us the indicators of type 2 inflammation, as well as how we can objectively look for evidence of type 2 inflammation. So thinking about indicators, when should type 2 inflammation come to us in our differential diagnosis? Comorbid late onset asthma, former surgery with tissue eosinophilia in histology, another part of the multidisciplinary approach. The pathologist is very heavily involved here. And also thinking about NSAID exacerbated disease. So evidence of type 2 inflammation, we can check eosinophil count in the blood or the tissue. So tissue EOs of 10 or more per high power field, blood EOs of 150 or more cells per microliter, and a total IgE of 100 or more international units per milliliter. These biomarkers can be very important in trying to determine treatment in patients who have type 2 inflammatory diseases. So what about the current treatment landscape? We're going to dive into this now. So these are the most common therapeutic interventions for CRS with NP. The saline irrigation, most patients will do this once they find relief, but I find that patients are often reluctant, and some patients say, are you trying to drown me with this? Intranasal and oral corticosteroids. We have traditional intranasal steroids, as well as the exhalational delivery device, which we'll be discussing next. And then when we think about oral corticosteroids, we think about short bursts and very few bursts per year. The side effects from oral steroids cannot be emphasized enough to patients. And so this is part of our cornerstone for therapeutic interventions for CRS with NP, but short bursts only. Sinus surgery is another therapeutic intervention, as well as biologic therapies, which we are going to get into in just a moment. So I mentioned the exhalation delivery system, and this is particularly with fluticasone, and it's the EDS FLU. And what this is you can see here on the cartoon, it is a breath-powered bidirectional drug delivery. The patient will place the device into their nostril without obstructing the other nostril. So the contralateral nostril is to remain open, unlike what we've told them with traditional nasal sprays. The patient blows into the device, which closes the soft palate. They press the bottle. It opens the valve to actuate the device for drug delivery. And the pressurized system leads to this bidirectional delivery of drug throughout the sinonasal cavity. And then the air exits through that unobstructed contralateral nostril. And by having this bidirectional drug delivery, there is more drug dispersed not only through the nostrils, but also up into the sinonasal cavity and into the sinuses themselves. And so when looking at the pooled efficacy of EDS FLU from the randomized controlled Reopen 1 and Reopen 2 trials, the co-primary endpoints were the composite symptom score, and this consisted of sinus pain, sinus pressure, nasal congestion and rhinorrhea, and sinus opacification. And this was a change from baseline to week 24, whereas the composite symptom score was changed from baseline to week 4. And as you can see here, looking at the least squares mean plus or minus standard error and treatment differences versus placebo with a 95% confidence interval, you can see that the EDS FLU delivery device had 5.5 points over placebo when looking at sinus opacification, and significantly increase also looking at that composite symptom score. And there was greater than 1 point from placebo. So there was marked improvement in both objective as well as subjective or PRO standpoint when looking at the exhalational delivery device in these patients that were enrolled in Reopen 1 and Reopen 2. Well, with this new exhalation delivery device, what about the safety? And this is looking at the pooled safety data. And these were adverse events occurring in 3% or more of patients and more common in either the exhalational delivery device group or then in the placebo group in the pooled data. And you can see the most common side effects that were reported were epistaxis, COVID-19, headache, and nasopharyngitis. Now, 2 doses of the EDS fluticasone were studied, 186 micrograms as well as 372 micrograms comparing to placebo. And you can see the number of participants there. There was about 10% epistaxis reported with all intranasal steroids. So this is consistent with that. And we would expect this to be higher at a higher dose, as is seen here. These trials were done during the pandemic. And so COVID-19 was one of the things that was certainly looked at. And you can see here there were some cases of that in both of the strengths of EDS fluticasone, and then headache and nasopharyngitis. But this pooled safety data does show a favorable safety profile for EDS fluticasone. So what are the risk factors for nasal polyp recurrence after surgery? So surgery, of course, being another one of our therapeutic cornerstones for the treatment of these patients with CRS with NP. But when we think about sinus surgery, we know that depending on what the studies you look at, there can be up to 40% recurrence of nasal polyps after undergoing surgery. So some of the risk factors that are associated with nasal polyp recurrence after surgery are listed here for you. So asthma, AERD, allergic fungal rhinosinusitis, smoking that makes everything worse, allergy, and then those patients, of course, often are thought to only have allergy, and often they will have CRS with NP. T2 inflammation, prior surgery being another risk factor for nasal polyp recurrence after surgery, and younger age. So these are all risk factors when you're having those shared decision-making discussions with patients about what therapeutic options that are available to them. This is important to point out because surgery is not always the end of the story for patients with CRS with NP. And another important point here is that post-surgical management really does need to be conducted by a multidisciplinary team. It's very important, again, not only from the patient's perspective, but also for improved outcomes and hopefully fewer evidence of or occurrences of recurrence. So what about the approved biologics for CRS with NP? Well, these are listed here. So currently, dupilumab, omalizumab, and mepolizumab are approved biologics for CRS with NP. All of these are subcutaneous injections, and all of these target T2 inflammation. Dupilumab targeting IL-4 and IL-13, and its FDA-approved indication for CRS with NP is as add-on maintenance for adults and pediatric patients 12 years of age and older with inadequately controlled CRS with NP with a dosing of 300 milligrams every 2 weeks. Omalizumab, another sub-Q biologic, targets IgE, and it is indicated as add-on maintenance for adults 18 years of age and older with inadequate response to intranasal corticosteroids for CRS with NP. Now, this dosing is variable from 75 to 600 milligrams every 2 to 4 weeks, depending on the patient's baseline IgE level as well as the patient's weight. And then mepolizumab targeting IL-5 indicated for add-on maintenance for adults aged 18 years of age and older with inadequate response to INCS for CRS with NP. And this dosing is 100 milligrams every 4 weeks. So now this looks like a very busy table. This is looking at the comparative effects of biologics as well as aspirin desensitization for CRS with NP. We don't have any head-to-head studies for these therapies, and this is looking at the classification of the quality of interventions. So it's comparing the biologics to each other as well as to aspirin desensitization. So to break it down and make it simple, the green boxes on the slide are indicating the most beneficial effects. So you can see looking at dupilumab, it has a large impact on the T2 inflammation, including the SNOT-22 score, the symptom visual analog scale, the UPSIT score, the smell score, rescue oral corticosteroids, as well as rescue polyp surgery with very few AEs. It is the only one that has green in all of the patient important outcomes, though omalizumab does also have significance in benefit with the quality of life SNOT-22, as well as the visual analog scale symptoms. And then mepolizumab also having benefit in the symptom VAS. It's important here that we note that aspirin desensitization still has importance and does have beneficial effects there, as seen again, mostly in the visual analog scale, but also in SNOT-22 and UPSIT. The thing about aspirin desensitization, of course, is the adverse events. Dupilumab, omalizumab, and mepolizumab have favorable adverse event profiles, whereas aspirin desensitization is a little more troublesome. And as we would expect, these patients can have GI side effects that can range from mild to severe, but they can also have bruising or bleeding due to the nature of the therapy being given to these patients. When we look at the surrogate outcomes, nasal polyp size, as well as the CT score, the Lund-Mackay score, we see again that dupilumab, had the most beneficial effects, dupilumab, and then omalizumab and mepolizumab also showing some benefit there. So this again is the comparative effects of biologics and aspirin desensitization for CRS with NP. I wouldn't review all of this in detail with our patients, but for me, it underscores the importance of looking for, identifying, and thinking about T2 inflammation in treating these patients. What about real-world treatment with dupilumab versus ESS, or endoscopic sinus surgery for CRS with NP? So this is a comparison of retrospective cohorts after about 12 months of treatment. And you can see there were a total of 111 CRS with NP patients who met modified inclusion criteria. And there were no statistically significant differences in baseline age, asthma status, aspirin exacerbated respiratory disease status, smell identification, LK polyp score, or that CT Lund-Mackay score between the surgery and biologic groups. And you can see that the greater SNOT-22 improvement in extranasal rhinologic domain scores and olfaction scores with dupilumab compared to ESS. Dupilumab treated patients reported improved olfaction, as well as decreased cough, postnasal drainage, and decrease in their thick nasal drainage, one of those cardinal symptoms. Patients undergoing ESS also had a greater reduction in their polyp burden. And that was in the matched cohorts. When looking at the observational cohorts, both dupilumab and ESS effectively improved outcomes in patients with severe CRS with NP, but dupilumab was associated with a greater improvement in the visual analog scale rhinorrhea, smell, and the SSIT scores, and this was statistically significant. They also had better control of local inflammation when treated with dupilumab and reduced need for oral corticosteroids with dupilumab. So this is that real-world treatment with dupilumab versus ESS for CRS with NP, looking at this after 12 months of treatment. What about real-world efficacy of biologics for CRS with NP? We know, as we mentioned, that dupilumab, omalizumab, and mepolizumab are all indicated for CRS with NP. And in looking at improvement in these real-world outcomes, SNOT-22, nasal congestion score, nasal polyp score, loss of smell, oral corticosteroid use, asthma control, and exacerbations in quality of life, again, dupilumab did show improvement across all of these real-world outcomes. Omalizumab hitting most of them, but not oral corticosteroid use, and mepolizumab hitting most of them as well, but not the nasal congestion score. So dupilumab has demonstrated enduring real-world efficacy after sustained therapy of 3 years. So how do we decide? We've talked about some of the most common treatments for CRS with NP. And of course, the most important thing is to have a shared decision-making discussion with our patients. But when we're defining therapeutic goals in CRS with NP, this is one way of looking at it. So looking at the y-axis, the absence of symptoms and signs of active disease. So that would be a therapeutic goal. Looking at the x-axis, on treatment, persistent treatment, or off treatment. So you may consider a patient controlled if they're on treatment and have not had symptoms at all in the last month. You may consider a patient to be in remission if they're persistently being treated but have had no symptoms or any endoscopic signs of active disease for 12 or more months. And you could consider calling a patient cured if they are off treatment and have had sustained remission for 5 or more years. And these therapeutic goals were defined in EPOS 2020 as well as Euphoria and published in Rhinology in 2024. So this is a good way to think about defining therapeutic goals and discussing these with your patient. So this is a proposed algorithm for the medical management of CRS with NP. The American College of Allergy, Asthma, and Immunologists created this algorithm or yardstick to help healthcare providers with the medical management of patients with rhinosinusitis for 12 or more weeks. And the first step is thinking of using the first-line therapies for all phenotypes, so intranasal corticosteroids, considering changing the mode of delivery if not achieving results initially. So if patients have gotten an over-the-counter intranasal steroid or has had one prescribed and it's not working as well, considering maybe the EDS device that we discussed, fluticasone, adding nasal irrigation, attempting to phenotype and endotype based on history, imaging, endoscopic, and histologic findings. This is important not only to drive our treatment, but also with insurance companies now requiring more and more detail with prior authorizations, we're kind of forced to have it, but it also helps us take better care of our patients. Then you diagnose the patient with CRS with NP and decide about second-line therapies, whether they need to undergo functional endoscopic sinus surgery with removal of the polyps, whether biologics are appropriate or oral corticosteroids. And if they also have AERD, think again about surgery, biologics, or oral steroids, and then that aspirin desensitization followed by long-term aspirin therapy. But this is a very important caveat. Aspirin desensitization is best done after debulking. So this is one population where we would strongly suggest having endoscopic sinus surgery and debulking to have the best success, and also the consideration of adding a leukotriene receptor antagonist or a 5-LO inhibitor. So this is the yardstick from the American College of Allergy, Asthma, and Immunology for the medical management of CRS with NP. I have repeated myself about the multidisciplinary management and how important it is not only for patients from their perspective, but for patient outcomes as well. And this is an algorithm for CRS with NP, thinking about that multidisciplinary management, the escalation of refractory disease. And this was published in 2021. And the multidisciplinary experts that were brought in to help create this were ENTs, otolaryngologists, pulmonologists, as well as allergist immunologists. And so for the majority of patients undergoing sinus surgery, they would get postoperative management. And if symptoms persist or recur despite the surgery, and appropriate postoperative care, considering comprehensive multi-specialty approach with shared decision-making. So biologics for patients with one or more indicated comorbidities, again, thinking about the T2 inflammation, whether it's asthma, allergies, or any of the others we have discussed, considering revision sinus surgery and possibly doing that before aspirin desensitization for those patients with comorbid AERD, of course, if not contraindicated, a steroid sinus implant. This is not done as often, but it's still something to consider. And then considering a short burst of oral corticosteroids to get symptoms under control. Assessing the response 6 months after the initiation of whichever treatment is determined best for your particular patient. And if the patient has persistent disease, going back up again and going through the algorithm one more time. Now, in a minority of patients, they may have a contraindication to surgery. They may have poorly controlled asthma despite the standard therapy. They may have oral corticosteroid-dependent asthma, or they may just not want surgery. So in this minority of patients, the algorithm looks just a little bit different because you would consider biologic therapy with either dupilumab, omalizumab, or mepolizumab, and skipping, of course, that surgery step. So thinking about the indications for biologic therapy in CRS with NP. So the Euphoria ePost 2023 update, looking at the indication for biologic treatment in CRS with NP, the presence of bilateral polyps in a patient who had ESS, and 3 criteria from the table below would be required to consider biologic therapy. So evidence of type 2 inflammation, whether tissue eosinophils of 10 or more, as we mentioned earlier, or blood eosinophils of 150 or greater, or a total IgE of 100 or greater. So evidence of type 2 inflammation with an objective scale there. The need for systemic corticosteroids, or they have a contraindication to systemic steroids. And that would be a cutoff point of 2 or more courses per year, or long-term, requiring low-dose steroids for 3 months or more. We really don't want our patients doing that if we can help it. Another criteria, significantly impaired quality of life, looking at the SNOT-22 being 40 or greater, significant loss of smell, and you can use that smell test that we have discussed, and the score, of course, depends on which test you use. And another criteria is diagnosis of comorbid asthma, and in the case of this asthma, requiring the need for inhaled corticosteroids for control. Now, some of the exceptional circumstances were not included, such as not being fit for surgery, etc. But for the Euphoria ePost 2023 update, these are the indications for biologic therapy. So how do we select the right biologic therapy with having 3 FDA-approved choices in front of us today? Number one, and I say this whenever I give a lecture on any disease, confirm that you have the right diagnosis. So confirming in this case that we have a diagnosis of uncontrolled severe CRS with NP, checking for those comorbidities and consequences, determining if T2 inflammation is likely, informing patient of all treatment options, perspectives, and risks. And this is a conversation that really I believe should be between the healthcare provider, the prescriber, and the patient, because one patient may want something that another patient does not. And we know that when patients are involved in the decision-making process for their therapies, they are more likely to be adherent, and therefore their outcomes may be better. The next step would be to select surgery or biologic, again, as mentioned, using shared decision-making, and then selecting the biologic drug that may be most advisable in the patient in front of you. So now I am going to turn it over to Nicholas Kalinsky. Dr. Kalinsky?
Thank you so much, Dr. O'Connor. That was extremely informative, fantastic presentation. Now we're going to get to talk about a case that I saw just a couple of weeks ago. If you want to advance the slide. So this is Leo. He's a 37-year-old male. He has a history of nasal polyps, and he was actually sent by his ENT physician for an evaluation for a biologic for his history of CRS with nasal polyps. He was diagnosed 15 years ago, and he's had multiple surgeries since then, most recently just a couple of weeks ago. When he presents to my office, he's absolutely miserable. He's complaining of persistent congestion, and he definitely does not want another surgery. He has a history of chronic headache, sinus pressure, postnasal drainage, colored drainage, and he has a loss of sense of smell and taste that he never really regained over the last 15 years, despite his many surgeries. He also has a history of runny nose, congestion, itchy, watery eyes, and postnasal drip year-round, and a history of asthma diagnosed at the age of 20. He also has a history of difficult-to-control diabetes, especially since he's been on multiple rounds of oral steroids for his history of CRS with nasal polyps. And he's failed multiple therapies, including high-dose nasal steroids as well as high volume nasal saline rinses. He's on albuterol and montelukast for his asthma. Next slide. So this is a discussion question. So Dr. O'Connor will kind of go over this. What are some explanations for the significant symptom return for Leo only 2 weeks after surgery before polyp regrowth when previous surgeries were 8 and 4 years apart? So after surgery, of course, there's going to be some inflammation of the nasal mucosa. Sometimes there can be packing in there that the ENT physician hasn't taken out yet. Of course, if the patient hasn't been adherent to nasal rinses, if they've been instructed to do so after surgery, that could also cause some symptoms. And then depending on how significant the surgery was and how much anatomy they removed, the patient could still have some persistent symptoms as well. Dr. O'Connor, do you have an opinion on this question?
I mean, I think you covered that perfectly, Dr. Kalinsky. I think everything you said is a possibility. We always have to think about that post-operative multidisciplinary plan and whether that happened and the adherence, right? Was Leo doing what he was told to do, and was he doing it correctly? But I think all of your explanations are wonderful, and I don't think I need to add any more to that.
Thank you. Next slide. So going over some physical exam findings, he had severe allergic shiners. Looking in his nose, he had some post-surgical changes and some scabbing from bilateral inferior turbinate reduction surgery. I did not see any nasal polyps. Listening to his lungs, he didn't have any wheezing, rales, or bronchi, but his asthma control test was low. It was uncontrolled at 12. And then his SNOT 22 was 78. So looking at your talk that you went over earlier, anything greater than 50 is considered severe. And it really demonstrated that I think he was uncontrolled and had some bad symptoms after his surgery. As far as other diagnostic tests, he had elevated eosinophil count of 750 and an IgE of 400, both key markers of type 2 inflammation. If you look down at the bottom, his FeNO or fractional exhaled nitric oxide was 55, also elevated. Anything greater than 50 can sometimes be consistent with eosinophilic asthma, CRS with nasal polyps, sinus disease, and type 2 inflammation. We also did a skin test in the office, and he was pan-allergic pretty much: trees, grass, weeds, dust mite, cockroach, cat, dog, and mold. We also performed a pulmonary function test in the office. He demonstrated 15% reversibility post-bronchodilator and FEV1, which would be also consistent with asthma. Next slide. So he had had a CT done before he saw his ear, nose, and throat physician. It showed pansinusitis and nasal passage changes consistent with the history of CRS with nasal polyps. He did have a rhinoscopy done with ENT, and it's important to realize the verbiage that was put into the clinical note, because this is going to be important as far as identifying the nasal polyp score and then getting the insurance company to potentially approve some of these biologic therapies if you choose to use those. The rhinoscopy demonstrated bilateral inferior turbinate hypertrophy and narrow nasal airways, also frank polyposis extending from the inferior aspect of the right superior turbinate and blocking a portion of the patient's nasal airway. And then on the left side, it also demonstrated polyposis extending from the middle meatus, extending beyond the border of the middle turbinate and medial to the middle turbinate as well, but not reaching the floor of the nasal cavity. So this is a score of 3 on the nasal polyp score on either side for a total of 6. And again, anything 5 or greater indicates severe nasal polyposis. There was also pathology done on the nasal tissue that demonstrated prominent eosinophils, focally greater than 10 eosinophils per high power field, and no evidence of malignancy. Again, this is a key marker of Th2 inflammation. Next slide. So this is a polling question. So how would you treat this patient? Would you start a biologic? Would you start their nasal medication? Would you start a biologic and the nasal medication, or would you wait for polyp regrowth? So we know he's had multiple surgeries, right? And he's been sent from his ear, nose, and throat physician to start the biologic. I don't know that he would want to wait for nasal polyp regrowth with how miserable he is.
I don't think that was on any of the algorithms.
Right. So it looks like the majority of individuals said start a biologic and nasal medications. I think that's a fantastic option. And we'll go over what I did in the clinic here soon. So next slide. So Leo was referred from ENT to initiate a biologic. but what are some of the treatment considerations and discussions you would have with him related to shared decision making? So there's a couple different things here. One, I think the expectation from both the ENT physician and from Leo is that he's going to start a biologic. I think, like Dr. O'Connor mentioned earlier, it's important to discuss all the different treatment options, efficacy, safety, side effects of which biologic you might choose, and then understanding that you would want to work with the ENT physician to manage this patient with CRS with nasal polyps. Dr. O'Connor, do you have any other comments?
Yeah, so I agree that I think the expectation and probably the choice that I would make in this patient is a biologic, but while waiting for the biologic to get prior authorized and all of that, there are some things that we could do that maybe would help him. Once he's cleared from the surgical perspective, we could think about the EDS for his intranasal corticosteroid. He hadn't tried that yet. Those high volume rinses could also be something. So just giving him some conservative add-ons to what he's already doing. So hopefully he can get some relief while waiting for the prior authorization, which can take, a week or so in some cases. When we think about the quality of life impact on this patient, that's not 22 and all of the different indicators of T2 inflammation, I would choose a biologic for this patient after that shared decision-making discussion, of course.
I completely agree. Fantastic. Next slide. So here's my treatment plan and what we ended up doing in clinic. So I believe that chronic rhinosinusitis with nasal polyps is more of a medical problem than a surgical problem, especially when he demonstrated that high Th2 profile. And so we recommended starting the biologic. We gave him a sample in the office. We were discussing on whether he should start high volume saline rinses with a topical steroid, but we decided to hold off given how recent he had his surgery until he could talk with his ENT physician. And he was actually going to meet with him just a couple of days after I saw him in clinic. For his asthma, I thought that he was uncontrolled because of his ACT score was low. And so I changed him to a high dose ICS or medium dose ICS LABA. And then I also put him on albuterol. It can be albuterol with a low dose of budesonide as well. And then because of his history of symptoms year round and a positive test demonstrating allergic rhinitis and conjunctivitis, we decided to put him on allergy shots as well. Next slide. So how long of a trial would you have Leo, or how long of a trial would you give Leo to assess biologic efficacy? 3 months, 6 months, or 9 months? And try to remember back to what Dr. O'Connor was saying in her previous slides.
The answer was there.
So we have a whole bunch of people saying 3 months, 6 months is fighting. So the majority said 3 months. What do you think about that, Dr. O'Connor?
Well, Dr. Kalinsky, I think that I would go for 6 months. I don't think it's wrong to reassess at 3 months. I think it's a good idea to always have a nice close watch on these patients. But about at 6 months is when I would start thinking that perhaps the biologic efficacy was or was not working. 9 months is a little bit long. So 6 months would be the answer. But I don't think you'd be wrong to look at these patients at all of these time points.
I completely agree. I think that discussing the case with the patient, seeing how they're doing, seeing if they've had any side effects after starting a biologic at that 3 month mark may be important. But as far as assessing on do we switch, maybe waiting until that 6 month mark. So we'll discuss that here shortly. Next slide.
The only other thing I would say is at that 3 month mark, if they aren't getting benefit and you do meet with them, you can encourage them, that to keep going. Because if we wait the whole 6 months before we ever talk to them, we may lose them on adherence.
Definitely. So this is from the EPOS and Euphoria 2023 update, evaluating the response to biologic treatment. You can see there at the top, defining response to biological treatment in CRS with nasal polyps. You evaluate 5 different criteria: reduced nasal polyp size, reduced need for systemic oral corticosteroids, improved quality of life, improved sense of smell, and then reduced impact of comorbidities. And you can see there on the right, and it's color coded, no response after 6 months. You may want to consider discontinuing treatment, essentially switching to another biologic or a different option. But if they have a score of 1 to 5, you may continue or consider continuing all the way out to 1 year and then reevaluate. And I think clinically, I would probably reevaluate, like Dr. O'Connor was saying, maybe earlier to kind of see how they're doing and either encourage them to continue with the therapy or consider switching depending on how they respond. Next slide. So what are some key points we can take away from this case? So me personally, again, I think that, of course, you want to get a great history, physical exam. You want to document your findings. You want to work with other specialists like the ENT physician, pathologist, so you can make the right diagnosis, come up with the right treatment plan. I think it's important to realize that maybe 40 to 50% of these patients are going to have recurrence of their nasal polyps after surgery. And I do think that depending on how good the surgeon is, will depend on a couple of different factors, and then also may influence your decision and the patient's decision on what you want to do and how compliant the patient is using medication, high volume saline rinses, topical steroids. That may decrease their risk of nasal polyp recurrence. But I think it's more of a medical problem than a surgical problem for most of these patients. So understanding when to use the biologic, I think, is important. Dr. O'Connor, do you have any other comments?
I agree with everything you said. And before I go to the official summary slide, I will say just one thing, of course, is always making sure you have the right diagnosis, CRS with NP, and also not minimizing people who come in with these symptoms and saying, oh, it's just allergies. Taking that deep dive, like you mentioned, Dr. Kalinsky, into that history and physical, because not every patient that looks like allergic rhinitis is simply allergic rhinitis. And also taking into account the frustration that these patients have when they've seen multiple specialists and still are not better. And not being afraid to discuss all of these therapeutic options with them, particularly when you've identified that T2 inflammation and looking at the data that we reviewed, and discussing that with your patient in an open manner and then making the decision that's best.
I completely agree.
That multidisciplinary approach, I think the second question here, I think that the allergists and the rhinologists need to be in conversation. Primary care needs to be involved. And as I mentioned, sometimes even the pathologist gets a phone call from me to find out how many EOs we're looking at. So we really need to talk to each other and coordinate care for these patients.
Exactly. And I think especially if the patients have other comorbid conditions, realizing that the patient has nasal polyps, many of those patients also have asthma. So working with the ENT physician, with the allergist, potentially with the pulmonologist, I think is really important. Of course, all of this can run together with atopic dermatitis. So you could even have a dermatologist in there as well. So I think those were fantastic points. Thank you.
Thank you very much. So to summarize and give you some key points, as we've pointed out, high symptom burden in patients with CRS with NP. This is detrimental not only to their physical health, but their psychological well-being as well. Effective disease management, as we have said, necessitates an accurate evaluation, making sure to establish the severity of the disease, identifying the comorbidities like Dr. Kalinsky just mentioned, and determining that level of disease control to guide optimal treatment selection. Surgical intervention is recommended and can be effective for patients, but polyp recurrence is frequent. And I think it's important to conclude by saying that biologic therapies are safe and effective for moderate to severe chronic rhinosinusitis with nasal polyposis and a good alternative to repeat surgeries and systemic steroid treatments for patients with poor disease control. I appreciate everybody attending tonight, and I'm very honored that I got to present with Dr. Kalinsky. Thank you very much. It was a very interesting case. And I would just thank everyone for their participation. Dr. Kalinsky?
Yes, thank everyone. I know everyone has a lot to do in the middle of the week, so we appreciate your attendance. And Dr. O'Connor, as always, thank you so much. It was a pleasure doing this presentation with you.
Thank you, you as well. Have a good night, everyone. Bye-bye.